diagnosis that will come into our mind. But the problem is this patient is a known case of coronary artery disease and hypothyroidism. She underwent mitral valve replacement with metallic valve few years back and was on oral anticoagulants with acetram 2 milligrams per day. And there was history of closed mitral valvotomy 20 years back for this patient. After that, 10 years back she underwent balloon mitral valvotomy, and few years, it means 2-3 years back, she underwent mitral valve replacement. Since then she was on oral anticoagulants. She is otherwise conscious, well oriented, and having signs of sepsis. It is tachycardia, tachypnea. Lungs for bilateral air entry is normal. Abdomen is diffuse tenderness is there, and guarding is there. 2D echo was done, which has shown normal functioning prosthetic valve, and there is dilated LA and normal LV function, moderate pulmonary hypertension. There is sinus tachycardia. INR was greater than 10. This is the problem. As she was on already anticoagulants and landed into sepsis, probably secondary to the intestinal obstruction, her INR is very high, and APTT is also more than 180, which is not recordable actually. And she landed in acute kidney injury also. Her creatinine is 2.6, which was normal 1 month before. She was on regular follow-up with us since mitral valve replacement. And she is anemic. There is leukocytosis and thrombocytosis. Her platelet count is more than 5 lakhs. So CT was done. Plain CT itself has shown signs of intestinal obstruction at the level of jejunum with possible bowel gangrene. We have not gone for contrast CT for this patient in view of her acute kidney injury, as plain CT itself has given some diagnosis which requires emergency surgery. This is the 2D echo report, which has shown moderate pulmonary hypertension with normal functioning mitral valve, metallic mitral valve, and INR is very high, and APTT is not recordable actually. Creatinine is high, anemia and thrombocytosis is there along with leukocytosis. CT has, the radiologist has given the suspicion of bowel gangrene, which is an absolute emergency for taking up for emergency laparotomy. At this point, the discussion is how to decrease the INR rapidly, as this is an absolute emergency. Each hour delay in surgery for this patient will increase mortality by 3 to 5%. In such scenario, how to decrease the INR is the discussion rapidly. What are the options available to decrease the INR? Can the chairperson's discussion? Mic.
So PCC concentrate.
This is very, most of the times it's not available readily. That is the problem with PCC. Actually, we have given an immediate IV injection of vitamin K, but the problem with vitamin K is it takes some time for the clotting factors to get restored. So our option is available is the easily available option is the fresh frozen plasma, and with fresh frozen plasma within 15 to 30 minutes we can revert the INR to normal levels when the patients were on vitamin K antagonists. Okay, and particularly this patient is already having acute kidney injury, moderate pulmonary hypertension, and sepsis. Here the problem is again not to overload, not to not to decrease the preload, particularly not to underload the patient. So we used the dynamic parameters in this patient. Particularly, we immediately at the emergency room itself went for invasive blood pressure monitoring, and we used the pulse pressure variation, particularly to titrate the fluids, as she is already at presentation itself is having tachycardia and tachypnea, which were the signs of landing into sepsis, and BP is also lower side for this patient. And fluid balance in the perioperative period is very important. Except pulse pressure variation and in the intraoperative period we can use can we rely on the CVP in this patient is the question. What about your opinion, ma'am? Can we rely on the CVP in this patient?
CVP will not be able to give the correct picture of the exact cardiac status.
Okay, okay, sir. So, we accept this pulse pressure variation as the patient is while in the intraoperative period. Any other parameters that can be used to titrate the fluid, as the surgery itself requires massive fluid shifts.
We can see the IVC collapsibility in this patient.
That is an intra-abdominal surgery, laparotomy, IVC collapsibility measurement may be difficult, sir. That is the problem that we faced. And we can we use this echocardiography?
TE, if at all we have the facility and expertise of taking help of TE, it would help us.
Yes, yes, sir. Actually, TE could be very useful in this patient. And if suppose if this is an elective surgery, and this is not, there is no absolute emergency, when we need to stop the acetram? That is the another question for elective surgery. That is actually how many days we have to wait after stopping the acetram?
72 hours, 72 to 3 to 5 days is the ideal time. Okay, and meanwhile we can bridge the patient with heparin, unfractionated heparin.
Okay, sir. Actually, what we follow is that after stopping acetram, when patient is posted for surgery, we do regular PT-INR. If the PT-INR is within INR is less than 1.5 or acceptable range, even not to, we won't wait for 3 days also. Can we take up surgery at that point? I think we can. I think we can, sir. And what are the how to monitor the acetram effect? One is PT-INR. Is there any other tests that were available to monitor the acetram effect? Is one more question, sir, for the discussion.
We can take help of TEG also if we have.
Okay, okay, sir. Okay. One more question is that even for emergency surgery, even after FFP, the INR is not coming down. What will be the other option except PCC? Is there any other options that will be? This is very important actually, that we can face the scenario, particularly when the patients were in sepsis on oral anticoagulants coming for an emergency surgery. Even after giving FFP, sometimes we may not achieve the INR to an acceptable range. And PCC is not easily available at most centers, and that is very costly also. What other options that were available, if at all any there?
We can try for cryoprecipitate.
Okay, okay, sir. Okay, thank you. Actually, the fibrinogen levels were, we usually do serum fibrinogen levels. If they are less than 200 milligrams per liter, we go for cryoprecipitate in that scenario. But most of the times, this with FFP itself, the INR will come down to normal, and we after FFP transfusion of 10 ml per kg, we did for this patient we did INR after 30 minutes. INR came down to 4. That is, and one more thing is that and how to maintain mechanical valve function, not to prevent its obstruction after stopping acetram is one more question, sir.
One thing is to maintain hydration part. Yes. If you can maintain the patient euvolemic status, to some extent it can help.
Okay, okay, sir. And one is hydration is a very good this thing to prevent the valve obstruction. But any other parameters that we can regularly monitor to see the valve is functioning normally, or to make it valve function normally when the patient received FFP and as surgery itself is a procoagulant state.
Transesophageal echo or the regular conventional echo,
Okay.
we can see directly the valve status.
Okay, sir. In this patient, actually, we have not used the transesophageal echo. We continuously simple auscultation, and we have continuously monitored the mechanical valve beating sound clicks. That we placed a stethoscope over the chest and fixed it, and we kept that entire throughout the period of surgery. We continuously at regular intervals we auscultated the cardiac sounds and made sure that valve valve is normally functioning by hearing the metallic sounds. That is one more thing. And surgery went well. And when to start the anticoagulants after a major surgery like laparotomy? That is one more question, sir.
With this, we have to take the help of a surgeon. From the surgical point of view, we should make sure that the drains are very minimal. Probably in the next 12 to 24 hours, we should be able to start the anticoagulation.
Okay, sir. And what anticoagulant that is preferred in a patient with acute kidney injury and on metallic valve in the post-operative period?
Conventional heparin would be the ideal one.
Okay, sir. If there is heparin resistance, or if heparin-induced thrombocytopenia is developing, is there any other option, particularly in acute kidney injury? That is one more point.
The problem with low molecular weight heparins are most of them they will be precipitating the kidney injury.
Yes.
Out of that, fondopyrinax would be the best choice if we have to use it.
Okay, sir. And will there be any use for heparinides?
I did not use any time.
Okay. I am also having no experience, but in one case where heparin-induced thrombocytopenia has developed, particularly in such scenario, we have an experience with the bivalirudin, which can be easily titratable, and it has very short half-life, less than half an hour of half-life, and it can be used for continuous infusion, and we can monitor the bivalirudin effect with APTT or ACT also. That for one case we have an experience with where a patient is having kidney injury, acute renal failure with heparin-induced thrombocytopenia. We have that experience. That is another option. We have kept ready bivalirudin for this patient, and after surgery and when patient was on anticoagulants, particularly with heparin or low molecular weight heparin, what are the available laboratory parameters to monitor the coagulation status, whether that is in acceptable range or not?
If patient is on heparin, we monitor with the APTT.
Yes, sir. The patient, suppose if the patient is on low molecular weight heparin, how can we monitor, sir? Is there any other available monitoring options? Is one more question for discussion here.
A regular BT-CT also will be.
Okay, sir. Actually, there is no easily available monitoring options when the patient was on low molecular weight heparin. But if needed, we can monitor. Is there any role for measuring the 10A levels?
Definitely.
But that is not available easily, routinely, sir. And what are the options of regional anesthesia in this patient in the post-operative period?
Since because of the coagulation issue, we will not be able to place an epidural catheter. So we have to rely on the paravertebral blocks or QL blocks or SL serratus erector spinae blocks.
Okay, quadratus lumborum block. Yeah. That actually, and is there any contraindication for the deep muscular, intramuscular blocks like quadratus lumborum block when the patient was on anticoagulation is another dilemma.
when compared to the epidural, this would be a safer option, but best would be the erector spinal block.
Yes, okay, thanks. And what will be the infective endocarditis prophylaxis option for a patient undergoing laparotomy with acute kidney injury with metallic valve?
Regular cardiologist. We'll go with regular IE prophylaxis.
Yes, thank you.
Renal protective drugs we have to choose, and regular amoxicillin can help.
For this patient, we have stopped a Citram. Already patient is having severe vomitings, and infective endocarditis prophylaxis was given with cephalosporins, and immediately 4 units of FFP was transfused. And in view of anemia, particularly hemoglobin is 8 grams, and is having moderate pulmonary hypertension. We have transfused 1 unit of packed cell in the ER itself, and vitamin K 10 milligrams IV given, and we have given 1.5 liters of fluids, and emergency laparotomy was planned. But after FFP transfusion, also her INR is 4. That is within half an hour itself we repeated the INR. So we repeated another 3 more units of FFP, and after this INR came down to 1.3, and we operated with the minimum amount of blood loss, acceptable blood loss of not blood loss is not that as we anticipated. It is around 1 liter only. So we transfused another 2 units of PRBC in the intraoperative period, and after fluid resuscitation and maintaining hemodynamics, our urine output improved. And the patient was shifted to ICU, extubated on the same day, and in the post surgery we have given 5,000 units IV heparin 3 times a day. Here is the dilemma is that whether to go for continuous infusion or intermittent doses of heparin is in dilemma, but we use intermittent heparin doses for this patient, and daily APTT was monitored. On day 5 enteral feeds were started, and once enteral feeds were started and renal function was normalized, we switched to low molecular heparin and started acetram also. For 3 days we continued the acetram and low molecular heparin, and on 3rd day we stopped the low molecular heparin, and with INR of around between 2 to 3, we discharged the patient and asked to follow with the surgeon within 1 week to check the INR again, whether that is in stable 2 to 3 or 2 to 4 range or not. Okay. Thank you, sir. Any questions or any inputs from the audience? Sir?
Thank you, Dr. Vamsi Krishna, sir.
Thank you.
For your
Sir, we'll take the questions after.